Mutations arise intrinsically as copying errors during viral replication. Severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, appears to mutate more slowly than other RNA viruses, including influenza and HIV, due to the fact that coronavirus polymerases have a proofreading mechanism. However, rare and substantial mutations in the spike protein close to the receptor binding domain have been observed. There is concern that mutations in the SARS-CoV-2 virus could potentially alter the structure of the spike protein, affecting binding of monoclonal antibodies or altering the pathogenicity of the virus. Single monoclonal antibodies, such as bamlanivimab, prevent viral infection by binding to a single epitope on the SARS-CoV-2 spike protein. Single antibody therapies may exert selective pressure on the virus, encouraging the spread of mutants that do not bind to the therapy. Dual monoclonal antibody therapies use a combination of two potent virus-neutralizing antibodies that bind non-competitively to the receptor-binding domain of the spike protein. Binding to two distinct areas on the spike protein diminishes the risk of treatment failure because variants must have mutations that modify both epitopes for viral escape. In September 2020, a new SARS-CoV-2 variant emerged in southeast England and rapidly became the dominant variant in the UK due to its enhanced transmissibility. Another variant emerged in late 2020 in Eastern Cape, South Africa, and has become the dominant strain locally, suggesting that the virus is more contagious than previous strains. Investigations are underway to determine if these mutations lead to treatment or vaccine resistance. In a recent trial, bamlanivimab was unable to bind to and neutralize the spike protein of the South African variant. Casirivimab had reduced activity against the South African variant compared with the original virus, but the combination of casirivimab and imdevimab remained potent against both the South African and UK variants. This supports the idea that the use of complementary antibodies reduces the risk of treatment failure by requiring the unlikely occurrence of simultaneous mutations at both epitopes for viral escape.